take off my mask since I'm way up here and I don't feel like I have to shout. Good afternoon, I'm glad you're all here. Dr. Mustian is an energetic, passionate, world-traveling yogi, scuba diver, foodie, and world-renowned cancer researcher who just happens to be an alum of UNCG Kinesiology Department. She spends her life working very hard to help people through lousy times when they encounter cancer. Dr. Mustian is the director of the University of Rochester Medical Center Peak Human Performance Clinical Research Laboratory, the co-director of the Wilmot Cancer Institute Cancer Prevention and Control Research Program, the co-director and MPI of the University of Rochester Cancer Center NCORP Research Base, and a tenured Dean's Distinguished Professor in the Department of Surgery and in Radiation Oncology in the School of Medicine and School of Dentistry. Dr. Mustian is the first woman with a non-clinical PhD to be an NCORP PI and the only exercise scientist to ever hold this position. She's a world leader in conducting large multi-center phase 3 clinical trials, testing exercise and behavioral interventions among cancer patients and survivors, with over 19 years of experience at the University of Rochester's Wilmot Cancer Institute. Her primary focus in cancer control and survivorship has been the effects of non-traditional exercise, such as yoga and Tai Chi, on the symptoms and side effects stemming from cancer and its treatments. Dr. Mustian is the PI for numerous local and nationwide clinical trials funded by NCI, NCCAM, NIR, and the DoD. She has acquired over $80 million in research funding and authored over 150 articles and book chapters in the field of exercise and cancer control. Nationally, Dr. Mustian is a new incoming federally appointed member of the National Cancer Institute Board of Scientific Advisors, and she is the first and only exercise scientist to ever be appointed to this board. And she was explaining to me last night that she's the board is the people who decide how the government gets to spend money on cancer, so I thought that was really cool. She is a longtime member of the NCI Symptom Management and Quality of Life Steering Committee and a chair of the American Society of Clinical Oncology Fatigue Treatment Guidelines Committee. Internationally, she's known as a leader in the fields of cancer control, survivorship, behavioral oncology, exercise oncology, and geriatric oncology, and she serves as the chair of the Multinational Association of Supportive Care in Cancer and the International Cancer-Related Fatigue Treatment Guidelines. She was recently named a Fulbright Scholar and a specialist for the Fulbright Nehru Commission in India, and she said that she is particularly proud of this collaborative work in India, where she has worked to set up the first exercise oncology program in that country. Dr. Mustian has been recognized for her excellence in research and leadership with more than 43 national and international awards. I'm very proud to have mentored her as a student when she was here at UNCG, and I'm proud to call her a colleague and friend. Please join me in a warm round of applause for Dr. Mustian.
I got a green light, so I think you can hear me, right? Awesome. So, wow, I have to say that it is really interesting to be back at UNCG as a speaker. I am incredibly humble and grateful to my experiences at UNCG. I had a lot of amazing professors. I owe the opportunity to ever being a graduate student at UNCG in the first place to Dr. Diane Gill, who's sitting here today. Had she not accepted me as her student into the program, I would have never had the opportunity to be doing what I do, which is what I love for a living, or to be here today talking with you. And also, I will mention to Dr. Weidman, who, as the story goes, for those of you who haven't heard it, is one of the only professors to ever really screw up my GPA as a grad student with her pharmacology and physiology class. But I also will say I probably learned an immense amount in that class, and without it, I definitely couldn't be doing what I'm doing today. I owe a lot, and I'm actually going to take this off. I owe a lot to UNCG. And one of the things I want to talk a little bit about is, before I launch into sharing my research, is sort of, you know, how I came to be here and I came to be doing what I'm doing. Because I don't think there are many people with degrees in exercise psychology and physiology and biomechanics and athletic medicine that have appointments in departments doing what I do in the surgery department and previously in radiation oncology. Now I hold an adjunct appointment there, or secondary appointment. And so how did I end up doing this, right? So I started out on a path like most of you. I think some of you are undergrads. And as an undergrad, when I was getting my degree, we didn't call it the fancy exercise science or kinesiology. We called it health and physical education. So no, just don't even believe I'm that old. Like, take that right out of your memory banks. All right? But when I came through, I had a choice. I got a teaching certificate to teach K through 12. I also specialized in athletic medicine because I thought I wanted to be an athletic trainer. And by the time I finished undergrad, I knew one thing for sure, that's I did not want to teach in public school, and two, that I really wanted to go to grad school, and I didn't quite know where it was all going to work out and land. I also didn't really want to be an athletic trainer in a public school, and there were not a lot of opportunities in the collegiate setting. And so I finished the degree, but I never took my NATA exam or anything like that. And then I started working, and I worked at East Carolina for a year as an instructor, and then I chaired a department at a large community college and worked there for 5 years. And that's where some things really started to change. And I should mention, I did do my first master's before I went on to take these positions in biomechanics, so I was dabbling in all potential areas of our field. I didn't really know where I was going to land. But when I was working during my years at Coastal, I ended up, I had the opportunity as a grad student doing biomechanics to work with Olympic athletes. I did some consulting. We were paid by the IOC and the USOC to work with javelin throwers and shot putters. So my first master's, I analyzed all the semifinals and finals of the shot put for the 1982 Barcelona Olympics. So I was getting quite a wide variety of different kinds of really cool experiences that I think a lot of exercise science students would give their right arm to have. But when I was working at Coastal and running the department, I was very embedded in the community. And I would say to you that 3 things happened that changed my life forever, and it's what caused me to end up at UNCG. One is that both of my grandmothers were diagnosed with cancer, and one of my grandmothers I was in particularly close to, and I took care of her through all of her treatments. And I still to this day get goosebumps when I talk about it, because I remember firsthand watching the nurses and the doctors and my parents and my aunts and my uncles having no clue how to help my grandmothers through all the pain and suffering that they were experiencing in the 80s as a result of the treatments that they were getting, which was supposed to be saving their life, but was making them incredibly, incredibly sick. And eventually I lost both of them to cancer. During the same time in my life, working at Coastal, the American Cancer Society came knocking on my door. And they said, hello, I was Coach M at the time, no doctor yet. Hello, Coach M, we've heard about you, we know what you do, we know that you do this work with, the softball team and the volleyball team, and you're working at Coastal, and we want to run this thing called the Relay for Life, where people get on the track and you do all this walking and running, and we don't have anybody to run it, but we know you're really good at that stuff, so will you come be the chair of it for us for the county where I was living at the time? And so I, for better or for worse, agreed. I chaired that event for them for the next 3 years. It was the first 3 years we held it in the county. We raised over $1.5 million every year we held the event. But in terms of working on that event, I got to work with cancer patients firsthand, who were going through treatment, who were using exercise, who were training to be able to come out and walk and do their part on the field. And so listening to their stories about how they would tell me, I had this black infection under my fingernails and it wouldn't go away. And when I first started walking or running, and it finally went away. And they would swear up and down to me that it was the exercise that was doing it, right? And then the third thing that happened, I got fortunate enough that my chair at the time, my dean at the time, was willing to send me off to Stevens Point, Wisconsin to the National Wellness Association meeting. And I thought I was going just to a stuffy conference to present things like we normally do, right, with all our posters and so forth. Little did I know I was going to end up in the middle of Wisconsin. I was going to be surrounded by Native American healers, South American shamans, yogis from India, Tai Chi masters, and people from all over the world that knew about Ayurvedic medicine and all kinds of things that represented a lot of bad words in our society at the time that we didn't want to talk about. And so those three things happened. And literally it was like one day I woke up and I said, you are not doing what you are supposed to do. You have a lot of knowledge. You've applied it to elite athletes for a long time, and these cancer patients need your help. And the story that Diane and most of them probably don't know is that I, like 3 days later, went and took my GRE, put in my application to grad school, only just like probably days before it was due. Okay? Didn't study for anything. And then when I got accepted, I put my house on the market, I sold more than half my belongings, and I moved into a little itty-bitty rinky-dink apartment over here in downtown Greensboro to start my PhD, right? And so I came here to a traditional department. Nobody was doing cancer research. Nobody really, I think, totally knew what to do with me because I wanted to study Tai Chi and yoga. And at that time, as I was telling some colleagues this morning, people thought that the words Tai Chi and yoga didn't represent exercise. I remember even some faculty members in our department saying to me, that's not really exercise. And I had to prove that, number one, it was exercise, make it so that it seemed credible, and move forward. So I'm delighted to say that our faculty here is really cool, and they actually supported me to do that. I got my dissertation done. I published the work on, I believe, 28 cancer survivors who did Tai Chi. It was a randomized 2-arm clinical trial. We compared Tai Chi to a psychoeducational support program, and still to this day, that is the first randomized clinical trial ever conducted with Tai Chi to breast cancer survivors in the world. We did it right here at UNCG. So that's how I'm here. And then I went, it's my story of like coming to this field of doing this work with cancer. So it's much more meaningful to me than just getting a degree and like, oh, this seems like a great way to get NIH money, right? So fast forward, I went to Rochester. I've been in Rochester ever since I left. I've done lots of traditional exercise research with walking and TheraBands and things like that. But what I really want to share with you today is what I am the most passionate about and believe in the most, which is my work with yoga. And those of you who know me or may have seen me at meetings present, now you'll know one thing: when you get to be a tenured, full, distinguished professor, you get to do what you want in terms of your research, right? Which makes a big difference. So that's what I want to share with you today. But before I launch into this really quick, does anybody have any questions? All right. So I probably have way more slides than I can get through. And oh, it's in my pocket. So we'll try to go through this. So I shared a little bit with you about why it all began, and I want to share something with you that still holds true today, to kind of start off this talk about my research. This is the opening lines of the very first paper I ever published with Dr. Gill. And I think when I read this to you and share this quote with you, I think you'll all know that it still holds very true today for women's health. So my wake-up call from my healer within came to me through my breasts. I think of it as my Amazon awakening. And so our breasts become a cultural battleground where a war is waged between our fear of living fully and our fear of dying before we've ever lived fully. And why do I like that quote, and why do I think it's important? Is because when I started this work in breast cancer and working with women, particularly women with breast cancer, we categorized cancer as a disease. We thought of it as a medical condition. And I don't think we fully appreciated all of the societal ideologies and ways that we think about treating a disease, but also valuing and understanding who we are as people, right? And who we are as a person with a particular biology or a particular makeup in terms of our bodies, or who we are in terms of the way we think of ourselves or our gendered behavior, and let alone our sexuality and sexual orientations and all those things that play together. And when you think about a woman, and the term woman, we were just talking about this earlier today, it's so hard to describe exactly what that term means in this day and age, okay? And as everyone likes to know, it's incredibly fluid, right? And we don't like the binary of it all, right? We don't want to be binary. We want things to be more fluid and more dynamic. Well, when you're faced with a disease, that part of the treatment is to actually sometimes take away specific body parts that society uses to identify you by a binary gender classification. It's far more devastating and far more of a difficult challenge than just whether or not you're going to be able to take a medicine and heal over that. Okay? It impacts everything. And when I did the focus group interviews with the women that I did early on in my career to prepare for my dissertation, the stories that they shared with me were incredibly powerful. And this quote, in many ways, sums it all up. I don't have to go through all of the different pieces of trying to understand that. When a woman is diagnosed with cancer, whether it's breast cancer, ovarian cancer, any different kinds of cancer, at the very core of it, it's not only a disease that she or they, or whichever pronoun you prefer to be called, is challenging. It's challenging in a multitude of ways, okay? So all of my work that I do with women is framed in that way. So the two clinical trials I'm going to share results with you from today were actually conducted in a large nationwide clinical trial research network that I now am the principal investigator of. This is a $30-some-odd million grant. We work with, now we actually have 22 NCORs around the country. Those of you that were just in the networking lunch with me when you met Dr. Hopkins, Dr. Hopkins is based at the big red dot right here, okay, which is all of us, where we were talking about collaborating on research. And all of the little green dots are different subcomponents of these red dots. And these are clinical oncology practices all around the United States, and they have little offsets off of them as well. That enroll people in the clinical trials that I and my team develop and design and conduct through the research base. We are the big blue dot in upstate New York. So why this clinical trial network is important is for two things. It provides a lot of infrastructure to get huge clinical trials done in cancer that we couldn't do otherwise. But the other part that's important is when you think about reach across the country to people who don't have access to a Chapel Hill or a Memorial Sloan Kettering or a Fred Hutch or an MD Anderson or even a Wellmont Cancer Institute, or even in some cases a nice big place like you have at Moses Cone, okay? This network is designed to not only provide care, but to provide access to clinical research trials for these people who live in not major cities and not by big, large academic medical centers, which makes the research that we do in our network a lot more applicable to the majority of Americans who live in this country, okay? So this network is really wonderful. It allows us to do gigantic, enormous clinical trials, as you will see. Represents now more than 1,000 community oncology practices across the country that we work with. And I will mention that prior to my joining the group at the UR, we didn't do any behavioral or exercise studies in this network. All right, so I'm going to go through this kind of quickly. So far I've conducted 2 studies using my Yokas yoga intervention, which I will explain to you in a moment. The first study was a study that involved 393 women diagnosed with cancer post-treatment. So this is as they were finishing chemotherapy and or radiation therapy and transitioning into survivorship. And we compared my yoga intervention to standard survivorship care, which at that time was ring the bell, walk out of the cancer center, shake your hand, congratulations, go have fun, see your doctor every 3 months. There was really no formal survivorship care. And we did a simple randomized clinical trial, pre-post assessments. The intervention lasted for 4 weeks. And I'll come back and talk to you about why we chose 4 weeks in a little bit. My second study, which we just recently completed and we're working on publishing, we enrolled 686 women. These are all different types of cancer. You can guess the majority are breast, but they were all different types of cancer. And here, since we had shown that our yoga was effective in the first trial, we decided, okay, now what we're going to do is we're going to come back, we're going to conduct a definite placebo control condition. And so we created a true survivorship health education curriculum based on the American Society of Clinical Oncology guidelines. It was a very, very active control group. It controlled for both specific and non-specific components of our yoga intervention. And then secondly, so this was a superiority hypothesis. Yoga will be better than the behavioral placebo. And then we did a non-inferiority test for our other primary outcome, which was that yoga would not be inferior to cognitive behavioral therapy for insomnia, because we believed it would be just as good as. Might not be better, but just as good as. And we did post-assessments, and then also we did 3 and 6 month follow-ups in that study, which we didn't get to do in our first trial. Both of these studies were funded by large grants from NCI in addition to the research base. And the first study was the very first grant I got as a brand new faculty member my first year on faculty at the University of Rochester. So what's our intervention? So we designed yoga for cancer survivors. We call it Yokas. It's a patented, copyrighted intervention that we have at the University of Rochester. It involves a gentle hatha yoga components as well as restorative yoga. It includes asanas, pranayama, and mindfulness activities. It lasts for 4 weeks, 75 minutes per session, 2 times a week, and we definitely encourage home practice. It's standardized. We use our yoga consultant, who's also a cancer survivor. We only hired Yoga Alliance certified instructors, and we have it completely manualized. At the time, we use DVDs and so forth to do this. And this is the yoga intervention we use in both studies. In the second study, the survivorship health education intervention that we used incorporated the content from the ASCO survivorship health education recommendations. It also included peer support. The components involved things like medical treatments and follow-ups, survivorship challenges, side effect management and rehabilitation, healthy lifestyle and support. It also lasted for 4 weeks, 75 minutes, 2 times a week, and to implement some of the strategies they were learning at home. In terms of standardization, we did the same thing. We only used we had a health education consultant. We used experienced and educated community health educators. We have manuals and PowerPoints. Everything is very scripted and discreet and very reproducible, right? Which is one of those things you all are going to have to talk about in your grants that you're writing. We're going to talk about tomorrow morning, right? And then for the last one, we used traditional cognitive behavioral therapy for insomnia. It involved sleep education, information on sleep hygiene, stimulus control, sleep restriction, cognitive behavioral therapy, sleep diary monitoring. This is a traditional tried and true model used by my colleagues at the VA. So we just took their model and we used it in this trial. This is 8 weeks long, 90 minutes, 1 time a week. Again, they have to implement strategies at home, and we standardized everything. the way we did for the other interventions. So some people are asking me why 8 weeks for this and not 4 weeks, and why not 8 weeks for the yoga, and why didn't you do all that? So this is a comparative effectiveness non-inferiority hypothesis. We don't want to make the yoga the same length or anything like that. We want to take the two interventions as shown to be effective and pit them head to head the way they're implemented in a clinic. Okay? So that's why we stayed with what was shown to work for yoga, and we are using what's used out there in the real world with the CBT, the way that it's done. We had great compliance and adherence. Our yoga participants attended, generally speaking, on average 6 of the 8 sessions, and the majority of them attended way more than 5 sessions. When we look, fewer participants withdrew from the yoga intervention compared to the SHE and the CBTI interventions. And they really reported finding the yoga useful in helping insomnia and say that they would recommend it to others. And in fact, some of the people in the CBTI condition talked about the fact that they didn't like it. And we had an extremely high dropout rate in that arm. And when you look at eventually at non-inferiority, I'm going to talk about this, you have to, if you have something that's highly effective and nobody will do it, it's not really highly effective, right? So what did we find in some of this? So in the first study, study 1, the take-home messages were that yoga participants had significant improvements in their sleep quality. They decreased their daytime sleepiness, and it significantly reduced their sleep medication use. So one big take-home message that caused this to hit everywhere like wildfire for the findings of this trial was that we allowed people to keep taking their sleep meds. And so the people in my control group, they increased their sleep meds here, and the yoga, they reduced their sleep meds, they did yoga, and they had even better improvements than the people in the control arm who could take as much sleep medicine as they wanted, and in fact did increase it over the course of those 4 weeks. So that was something that really opened up the eyes of a lot of clinicians. And then in the second study, when we went on to compare it to the survivorship, health education, behavioral placebo, we found that it is significantly better at improving insomnia compared to a behavioral placebo. And there I'm showing you the data there in terms of the trial. So even though, and I will mention, because the study I'm doing now, you can see that we have improvements in sleep in both conditions. So it's not that our behavioral placebo was innocuous. It wasn't. In fact, it was better than we thought it was going to be. But still, the yoga was significantly better. Right? So it is the preferred treatment at this point, clinically. So then I went on to talk about non-inferiority. So how did this compare to the cognitive behavioral therapy? And before I talk about that, I want to talk quickly about, so how do you establish non-inferiority? Because people don't always know this, and honestly, when I was designing this trial, I didn't know it myself very well either. And then when I was analyzing, I still was scratching my head sometimes to try to figure it all out. It's like a little black box. But I think we got it. All right? So the first thing you do is, a priori, you have to define a non-inferiority margin, which is different. So in a superiority trial, you define an effect size. How much better do I think this is going to be than the thing I'm comparing it to? In a non-inferiority, you do the opposite. If it's not less than this amount lower in its effect, then it's okay. I consider it equivalent, okay? So instead of defining the effect size, you define how far below the effect of this condition that I'm comparing it to will I allow yoga to be and still call it effective enough, okay? So you have to define that up front. Your participants have to be blinded, so they have to be undergoing 2 interventions that they have full capacity to believe that they will be equally beneficial to them, okay? And then active comparison with optimal dosing. So you have to do an intent to treat analysis, which means you have to analyze people to the arms they're randomized to, regardless of whether they do your intervention or not. Okay, they still get to stay in that same arm. And then you deal with your missing data differently as part of that as well. But And then you do what's called per protocol, which means you analyze all comers in the first one, and then the second one you only analyze the people that did exactly what you prescribed for them to do. And the findings from those two have to concur for it to fully be deemed inferior or non-inferior, okay? And for this one, it's pretty simple. You don't really do ANCOVAs or a lot of analyses, you plot it. You plot it and you look at the confidence intervals and you look at where things fall in terms of these lines. And here's an explanation of something that would be inferior, inconclusive, non-inferior, or superior, okay? What did we find? So here you have the blue dots represent the intent to treat analyses, the yellow dots represent the per protocol analyses. We have immediately post, 3 months and 6 months intervention, okay? So at first, when you look at the intent to treat analysis, the data is suggesting that the yoga intervention as we delivered it and we designed it is inferior to CBTI and not as good. However, at all 3 time points, post, 3 month, and 6 month. However, when you look at per protocol, which means the people who actually did what you asked them to do, it's inconclusive because you have the tails of the 95 confidence intervals percent overlapping. So at this point, we're scratching our heads. Of course, you know I wanted all those blue dot lines to like go way over the non-inferiority margin, right? I'm not worried about it because I do believe at some point if we just increase the dose of yoga a little bit longer, and there's some things to think about. So I got the effect I got with yoga in half the time. I got it in 4 weeks instead of 8 weeks. When you also go back and you look at the attendance, and attendance is something you have to take into account and how many people actually did what I asked them to do. The dropout rate in the CBTI group was significantly worse compared to the yoga group, and people wrote all over their feedback that they didn't like the CBTI. And in the clinical sleep world, that's one of the issues that we have with CBTI is that patients report not liking it, it's not easy to adhere to. You have a patient in the middle of chemotherapy who's exhausted during the day and you're telling them not to nap for longer than 15 minutes. It becomes a little bit inhumane to ask people to do that. So these are why we're looking for alternatives to CBTI. Does it work when you can do it? Yes, it does. It knocks the ball out of the park. The problem is a lot of people can't do it. So enter yoga. You're going to get a tremendous effect on your sleep. Maybe not quite as good as that in 8 weeks, but still very, very good. Better than a behavioral placebo, better than nothing. It's much more pleasant, much more easier to do. People like doing it, right? So yoga is still in the game as a potential, gold standard therapy for sleep. We just have to tweak it a little bit, I think, and keep going back with us. And I think we'll hit what we need in terms of that prescription. So we've done a lot of other work with the data off of all of these trials. And I want to share it with you briefly, but I want to leave time for questions too. So we also found that our yoga intervention significantly improves fatigue. In our first trial, our participants reduced their fatigue by 41%.